It's a great pleasure to welcome you here today on this balmy Sydney morning, and isn't it great to see the rain? But before we get into the formalities, I'd like to invite Vanessa Lee to give the acknowledgement to country. Vanessa is one of our early career researchers doing her PhD in public health.
Good morning, everybody. My name is Vanessa Lee. I'm a descendant of the Miriam people and the Yapungathi people of Cape York and the Torres Strait. So traditionally I can only give an acknowledgement to country. And I would like to acknowledge the Gadigal people of the Eora Nation, of the land of which we are having breakfast on today. And I'd also like to pay my respect to their culture and their histories. And I'd like to extend that respect further to the Indigenous people that are here with us and also to the non-Indigenous people that are present. Thank you.
The theme was actually stimulated by something that Liz Forsyth said to me when I was a brand new dean. We have a frank and fearless external advisory committee for the faculty, and Liz is a member, and she said really early on, Kathy, you are not about producing fodder for the health system. And yeah, I know that's shocking and I know it's provocative, but actually when you think of the health reform agenda, that's exactly what it's about. It's about a new workforce, a new vision for health. So I just want to talk a little bit about what we're doing in that space. So if we are now about educating new health professionals to meet the challenges of the future health of the community, so that we can meet future needs, but we need to really partner with you. But the questions that come out of that are, what is health going to look like? Therefore, what should our health professionals look like? So there are some things that we know. The projections are that in the next couple of decades, 1 in 4 people will be working in health. $110 billion will be the health budget, and I think that that is about 6 or 7 times the whole budget of the whole state of New South Wales. So clearly that's not particularly sustainable. We know already that the health profile is changing in our community, that the burden of disease is about chronic disease. 70% of the burden of disease and the cost is chronic disease, and that's managed in primary care. So it's obesity and the consequent diabetes, cardiovascular disease, and things like musculoskeletal conditions. Back pain is the biggest burden of disease globally, all managed in primary care. We already have inequity of access to care, so that it's not readily available, and it's not just for people in remote regions. Even in Sydney, there's uneven standards of care, there's uneven availability of care. So, of course, the health reform agenda is aimed at these kinds of issues. The 2 key elements in the reform agenda that relate to us, particularly, well, in allied health in particular, the focus on primary care and the management of chronic disease, because we just haven't got it right. We cannot cure most of them. I mean, obviously, that's why they're chronic. And preventive care, which we really focus very little on. So the strategies that the Commonwealth is looking at to meet these challenges are looking at innovative funding methods, like funding health outcomes rather than throughput, which has been on the agenda for a long time, but it's a really different way of thinking about it. And finally, it might stop us doing things like arthroscopies, all the things that are ineffective or harmful. Stop us ordering images for back pain, except in rare, really rare cases. No more X-rays, CTs, MRIs for back pain. The really key thing, though, is that they're focusing on the labour market reform in health. That is us. That's the education providers. We've got to be doing something differently. And e-health, enabling access and affordability and sustainability. So I've been to quite a few discussions about health reform, and they've always been quite siloed. So people are talking about fee-for-service, or private versus public funding, or imaging, all in silos, and not really thinking of the whole. And when we're thinking about health reform, we really need to think of the whole and the whole envelope. And an image that Jane Holton often uses is that, like, the left foot really intimately, and you know the right foot intimately, and at the back you know bits of the brain, but no one sees the whole. No one sees the whole elephant, that it's an elephant, whether it's fit for purpose, whether the shape and size is right, whether it's pointing in the right direction. So it's one of the challenges today to keep the whole in our minds while we're talking about some of the issues. The vision for policymakers and decision makers globally here is for an affordable, effective, joined up system. And in fact, most importantly, it's what the community needs, where we're working in teams, where the patient is at the centre of care. But that's not matched by the culture of the professionals and the professions, and indeed by the academics. So we need to really look at ourselves and to debate that, ourselves and you together, to debate some of those key issues and to challenge each other so that we can actually educate the new professionals for the new generation of health. So I think then, you know, culture eats strategy for breakfast. If you don't have the culture right, the strategy is not going to work. But together we can then design a health system that is for the patients, it's for the community to keep them well. It's not for the professionals and it's not for the professional bodies. Our vision is to change the workforce. We say we're educating the new health practitioners for the new era, for the changing health landscape. But what to? So that's the landscape that we need to address. We know that when you embed research with healthcare delivery, with clinical education, you get better health outcomes for patients. We are educating our students in that way. They can bring all those things to the health sector. We also know that to translate findings into practice, we need two-way translation. So we shouldn't be just inventing a new idea in our office. We should be working, a lot of those ideas should be generated by clinicians and by patients. That's the only way that you're really going to get translatable research. You know, 50% of effective treatments are not translatable. We cannot put them into practice because they were designed inappropriately. So what we're doing about this, we're doing quite a few things in the faculty. All our students, well, we're rolling out e-health. We're embedding it in every program. We've started with 3, and by next year, all our programs will have e-health embedded. So all our students will know how to use technology in their daily practice and when to use it and when not to. Another important initiative is that we have started a leadership mentorship scheme. The leaders were chief executives of non-government organisations, chief executives, CEOs of non-government organisations, chief executives of local health districts, senior partner of KPMG, and we don't have a politician. And I said I'd put Jillian, the minister, on the spot. We haven't had a politician, and why shouldn't allied health be in politics? So we're planning for that next year. So we partnered our leading, it was competitive, so it's a few students across the whole faculty, and we partnered them with very senior people in the health sector. And I've just been reading the feedback, and it was really quite emotional. The students found it transformative. I think for the mentors, it was not very taxing, but for the mentees, I'm telling them it wasn't very taxing, but for the mentees, it was totally transformative. They're sitting at a table, a board meeting, and with Teresa Anderson, for example, who makes every person around that table have an opinion. So an undergraduate student is sitting with the most senior people in an organisation, and they have to have an opinion. So they came out of that experience knowing how the whole system works, how they can contribute, how to come forward with a value proposition, not to sit around wringing their hands and saying, what about us and what about me, but actually to come with a value proposition. So we're graduating different kinds of health professionals. They also, I should say, are starting initiatives that there were previously no resources in the institution. So our students have started multidisciplinary clinics for chronic disease. Our students have started rehab clinics for stroke rehab and cardiac rehab, where those services did not previously exist. So they're learning how to do multidisciplinary care, how to establish clinics. They're learning a lot of different skills. But this means that we're graduating a different kind of health professional. And it means that when they come to you, they will be asking challenging questions. They'll be saying, why are you doing this treatment that's not effective? The research says this. Who's funding this? It's very expensive. They will be asking different kinds of questions, and they will be wanting to practice in a different kind of way. So I have to say that we need friends. We need friends in this endeavour, because there's no point in us educating practitioners in a different way if you don't want them, if there's not a place for them to flourish in the clinic and after they graduate. But I'm just telling you that there's a huge benefit in having them. So finally, I'll just briefly tell you who's here so that you can mingle with each other afterwards. We've got the Vice-Chancellor and the Chancellor and Deputy Vice-Chancellor Indigenous Strategy and Services here. From the faculty, we've got professors, the leading researchers in their areas like breast cancer and imaging, disability, speech and communication disorders, physical activity from the bubble wrap, pop the bubble wrap for children through to healthy ageing. We've got some early and mid-career, a few early and mid-career academics. They're our energetic next generation who will be leading our side of education in the health reform agenda. They're the ones that are helping to shape the vision now, and they will be the custodians of the vision in the future. We've got about 170 external people here today, and they are the CEOs of non-government organisations. They're the chief executives of local health district. We've got industry, we've got research collaborators, we've got some alumni, and we've got, I hope, consumers. We are all health consumers, but we have a very special consumer here today who's also on our advisory board. So I challenge you now to really debate these issues and reflect on what we're doing and how we're going to work together to make the change. We really need to partner with you in all these endeavours and are really willing collaborators to help you achieve your goals and us to achieve ours. Professor Stephen Leader, who needs no introduction to many, but for those who don't know, Steve is Emeritus Professor of Public Health and Community Medicine, and he's the chair of the board of Western Sydney Local Health District, and he's a fearless, scary MC. I hope he's going to challenge us today.
Yes, I was just about to ask you to sit down, Kathy, because this extended commercial moment is chewing into the... But that was wonderful. It was a very passionate and wide-ranging introduction to the day's proceedings. So just so that you know what form the program will take, we have a panel of 3 people who will each speak briefly, and then there will be an opportunity for discussion and questions and perspectives from the audience, and then summing up at the conclusion. I was thinking, just looking around the room, just that we should take stock and consider how fortunate we are to be in this room. By any reckoning, historical or geographic or demographic, the opportunity to meet in the way that we're meeting here today is a very rare one. And it's a product of the luxury of the society that we live in, of the intellectual heritage that we have, and a country that really values health, and it really values education. And sometimes when we get all the political ripples in the system, we get a bit storm-tossed and lose sight of the great privilege that we have provided to us to make a difference. And the point of the difference that we want to talk about today is how we equip the health workforce for the future to be flexible and capable in its adaptation to changing circumstances. We know very well that chronic diseases are the dominant agenda item now and in the next 2 decades. I wonder what it'll be after that. If there's a cure or prevention for dementia, how's that going to change the system? Immensely would be the answer. And these are things that we can't predict, but we can anticipate. So we're thinking about today the way in which we educate the future workforce, and as Kathy has said, how that education forms the beginning of a collaborative relationship with health service providers so that we do the best we can for the community that we serve together. So let me start by welcoming the Honourable Jillian Skinner, Minister for Health and Minister for Medical Research in New South Wales. Jillian was first elected to State Parliament in 1994, and she's since been re-elected on 5 occasions. She began a career as a journalist in Melbourne, and somehow, by working in the parliamentary gallery, I gather, caught the bug. And so we now see her as a very prominent person in politics in New South Wales, and we've been favoured by Jillian's immense enthusiasm, her experience of watching from the sidelines as Shadow Minister for over a decade, and she brings to the portfolio experience and passion and clarity of purpose and a pretty hefty degree of political muscle, which is essential. So, Jillian, we're delighted to have you with us this morning, and we ask you to make your remarks now.
Thank you. Thank you very much, Stephen. And my remarks really are going to take the form of a couple of stories. When I was appointed minister after we won the election in March 2011, it was really an opportunity to put into place a lot of things that I'd been thinking about as Shadow Minister for the previous 16 years. And there are people in this room who helped me on that journey in understanding the things that needed to be done. But the reforms we've made so far, which really have been about devolution, about appointing boards that really have changed the way the health workforce works at the local level. So I'll tell you the story about yesterday. Yesterday I took the new Premier down to Wagga Wagga. He requested an opportunity to go and have a look at what we were doing in rural New South Wales. And I'd said to he and the new Minister for Mental Health on the way down, don't be fooled that it's all just about rebuilding the infrastructure. That is a terribly important element of what we're doing, but it is what that does. And I was saying to them, it's changed the way we practice. I couldn't have described it better than the young man who met us at the door of the new mental health facility and took us through describing how, because of this new building, because of the way it had been designed, engaging the consumers, the practitioners, they were now treating patients differently, that patients had a better deal. And what happens is they come into an area, if they have they're very seriously unwell, an area that's calm, where the professionals come in and they are now working in a much different way, where they're calming down, they're working in teams to settle them. Then they go into acute areas, then they go to the subacute area, which is on the top floor of this building, and it has 3 pods, quite extensive. This building has now 50 beds, and in that subacute floor, there are 2 nurses, 2 for the whole floor. Who are the others looking after these patients? Well, to a large extent, they are now starting to look after themselves, and they're helped on the way by occupational therapists, physiotherapists. I'm not allowed to use the word allied health, I'm told, because that's now becoming, well, it is allied health, yes, thank you. These are all allied health professionals, and on that floor, non-government organisations that are funded to provide community-based care are involved, and a representative of one of the medico locals, or the primary healthcare sector. They are working in collaboration and partnership, so what happens? These patients spend less time in the acute area, they get better quicker, they go into what is really rehabilitation and preparedness for independent living with the help of that workforce, and then they're discharged into the community with the care of somebody in the community watching out for them so that they are not being readmitted. And this has an amazing impact on the mental health of the people, not just in Wagga, but in the whole district, because another part of the ground floor is about telehealth. And they've got a whole setup there that links to every other small facility and others out in the community. So there's a whole new range of workforce demands and skills. People working together, understanding that they're working differently, that they're working in the community, and it's just as important to work in the community. Elsewhere in country New South Wales, we've had an issue where we're changing the roles of some of our nurses who have been working in some of the smaller facilities where the roles are changing. They are now being allocated work out in the community. Now, I think in the past that was seen as a negative, that was seen as a demotion. Not at all. That is the new way. I want to just refer to something I wrote, because really it's now about we've done these reforms, we're improving enormously what's happening in our hospitals. I'm very proud of an Australian Institute of Health and Welfare report that comes out today that shows New South Wales is now leading in terms of emergency department and elective surgery performance, and we'll continue to focus on that. But it is now about integrated care. And I want to read you something that I wrote as Shadow Health Minister, because Shadow Health Ministers have got no staff, they do everything themselves. I hope the Labor Party now realises that. The only political comment I'll make all morning. But in March 2009, before there was any discussion at a Commonwealth level about COAG health reform, I wrote this. It was in the context of creating local health districts and giving them, putting boards on to govern them. And I say this, they will take into account the boundaries of divisions of general practice, changed but nevertheless primary health care, to facilitate the development of partnerships which will provide a seamless range of healthcare services to people who need them, whether that involves hospital treatment or community-based primary health care services provided by general practitioners, pharmacists, or other allied health professionals. I wrote that in 2009, and that is our new agenda. That is the reform I'm really now pushing as my priority. There's wonderful work, no, don't clap yet, it's not there. We have allocated $120 million from the central pool of resources over the next 4 years, which is a starting point. May well be more if we get some fabulous ideas. And we've said to local health districts, put up some of your growth funding, because they all get growth funding despite what you might read in the press, that put up some of your growth funding, entice others in partnership to put money in, and let's do this seamless care, this integrated care. I imagine that will create totally different working relationships and requirements, skill requirements. And I know that Heather Gray, who is the director of the chief executive of HETI, the Health Education Training Institute, will be there with her wonderful range of training provisions, and I know universities and others will be too, to help us get those skills going. So, you know, the very specialist roles of people, whether they're doctors or nurses or allied health or health professionals, will have to be much broader. They'll have to be much more of generalist persuasion. They'll need skills in management. They'll need skills in budget management. And these are some of the things that Heather has been working on for our boards. Our boards now have a range of representatives on them. They have clinicians, they have people with legal backgrounds, with financial backgrounds, and they are all working together. That's how it must be, because they now have that responsibility. I just want to end with one more story. And it came out of, we've allocated $1 million to start the planning of the the redevelopment of Westmead Hospital campus. And I use the word campus advisedly. And I was at a meeting, I see Danny O'Connor down there smiling. I was at a meeting recently to hear, it was a round table, to hear different views from different people within that campus about what they were discussing in this context. And they had somebody from the children's hospital, the adult hospital, the dental hospital, the private hospital, from universities, from the medical research facilities. And I guess the message that got through to me most was one delivered by somebody from the children's hospital who said, we now have a different dilemma, different milieu that we work in. Children who previously had a disease that meant their life expectancy was probably no more than 15, now live on. They live beyond the 16, 17, 18 mark, where they will be discharged, no longer eligible for children's paediatric care in our hospital, which is all-enveloping. It's not just the specialists, it's all of those other people that comprise the team that look after children in our hospital so well. So now they're discharged and they become a patient of an adult hospital, which, while it's fantastic, is absolutely siloed. So they don't have the whole person cared for. So what we need now, this person said, was a transition. We need to have a capacity to treat those patients as children, teenagers and adults in that all-enveloping way that is so important in chronic disease. I think it was absolutely spectacular that we had people talking about the care element, the clinical care of a patient in the context of how we design now the buildings. That's how it should be. Let's not go in and build a building and then say, how are we going to fit everyone in? Let's work out how we're all going to work differently, in different ways, you know, nurse practitioners, allied health people, more generalist, taking the lead. And by the way, we do have an allied health Member of Parliament. We have several nurses, a dentist and an allied health, just on our side of politics, so watch this space. None of them are going to be the health minister while I'm around. And anyway, so we'll talk. So look, there's plenty of scope to do brilliant things if we all work together and we all understand the importance of designing the training, the skills set, and then taking them on board as we move into the whole new area of health delivery. So thank you very much, everyone.
Thank you very much for that, Jillian, and we look forward to further conversation in the question time about that. Now, you've been issued with these little keypads, and I think it's probably the best way to understand what they do is to try it out. And we're going to present to you from time to time with a question, a series of polling options, and depending on your response, you click the appropriate thing, A, B, C, D, or whatever, and then that's displayed on the screen. I guess most of you have used these things previously. And so let me call up the first question, if I might, which is, what is the most significant workforce challenge in Australia? And you have a range of options there that you can now exercise your thumb, or whichever digit you prefer, to press, and then we'll see what the result won't be. So away you go. Whoa, there you go. Enabling the health workforce to adopt different service delivery modes. So that's the answer for you, Kathy. That's good. You've done well. You've done well. It is interesting, though, isn't it, that is a structural response in lots of ways, saying let's make sure, as Jillian said, that the structure does not inhibit the adoption of different service delivery models, including the sort that determines the professional category in which we operate. So thank you for that. Ms. Liz Forsyth, who's a partner in charge of the National Health and Human Services practice inside KPMG. She's a senior partner there and lead for the Health, Ageing and Human Services section of KPMG. She's also Deputy Chairperson of KPMG Australia, as well as being on the board of the Health Sciences faculty, as Kathy said previously. She has extensive experience as an advisor to government, working for more than 13 years as a senior executive in Commonwealth and state governments, and having direct experience as a service delivery practitioner. Her driving passion when working in health and social policy reform is to see that issues related to disadvantage, disability and vulnerability receive the attention that they deserve. So thank you for being with us this morning, Liz, and look forward to hearing from you. Liz Forsyth.
Thank you. I'm going to take the words that have already been spoken about the nature of the health reform agenda, what's happening within our health system, and our considerations as to what's happening in our tertiary institutions, and look at this issue from the perspective of a graduate. Because one of the things that we really need to do is we really need to think about the capabilities and the skills and the competencies that we are engendering in the people that will work in the health system of the future. I'm actually a relatively large employer of health professionals. They tend to come to me either as graduates or having worked in the system for a while looking for an alternative career opportunity. I also sit on the advisory board for the health sciences faculty and have a look at the types of programs and capabilities and focus that we are placing upon young people that want to work in the health system. And what I would like to say is I think our focus is imbalanced. We're very confident that when we secure graduates that they're technically capable, and we know that they will continue to grow their technical capabilities. So for me, that's just not an issue. But the real challenge is the skills that you need to work in the workplace. One of the biggest challenges for us is actually getting graduates that can write in a way that is consumable to the business environment. And yes, disciplines are learnt well within university, but the capacity to convey clear messages succinctly, to rationally produce an argument about options and then reach an informed conclusion based on evidence from an array of perspectives is actually a real challenge. And what we find is the need for competent writing skills, the need for competent communication skills. How many times have I met with graduates that can't maintain eye contact, that actually can't have a conversation about other things than matters related to work, that can't build the rapport that are so necessary to build strong interpersonal relationships that are critical for the new ways of working that we are describing in the health system. And so interpersonal skills for me is one of the major areas that we really need to bring back into the curriculum as part of the repertoire and capabilities that we need to see our graduates emerge with, because they will be placed in complex work settings. We are increasingly going to move away from rules-based ways of working to working in teams, to working collaboratively, to even doing something called co-design, where you bring all the stakeholders together, including consumers, family members, other professionals, bureaucrats, to solve problems. That's the way of the future, and the capacity to work within that context is very challenging if you don't have the prerequisite interpersonal skills. And so that is an area for me of focus. Another area of focus that we really need to think about is working in teams. And rigid attempts to refine one's role down to I do this and you do that are things of the past. We talk about multidisciplinary approaches, it doesn't go far enough. We need to think more about transdisciplinary approaches Where do we need that specialist input, and where can we share that capability and that competency across disciplines, because our workforce will be constrained in the future. We won't have the breadth of supply that we need today or in the future, and we're going to have to adapt. And we're going to need to look to professionals to be much more agile and flexible and work across those boundaries that have maybe traditionally defined who and what they are. And so looking at ways of working within teams, understanding the wider contribution you can make, recognising the aggregated value is more than the individual, is something that we need to start engendering early on, because it requires quite different skills and quite a different approach. Technology is also going to be important. Regardless of whether you like it or not, it's here to stay. Most of our graduates are very competent in it, but they need to think about its adaptive value within the workplace and how they can use that to inform the way that they relate to their patients, other team members. They can bring information and evidence to bear to make real-time decisions based on decent facts. Now, yes, our systems are somewhere behind, but technology and the ability to interpret information and then apply it within the working context will be an increasingly important part of the way that we see the health system moving in the future as it responds to real-time trends and emerging issues. The third area of consideration for me is getting the balance right in terms of understanding how the health system operates and the technical capabilities that you need as professionals working within that system with commercial acumen. And this is not because you all want to run for-profit organisations, but there are tangible challenges out there that the health system confronts today. It confronted 20 years ago, and it will confront the same issues going forward. The demand for resources in the health system is so extraordinary that we have to make better decisions about how we spend that which is available. And to make those better decisions, we have to understand how the money works. We have to understand how we deploy the other resources available to us, whether that be infrastructure, people, technology, or whatever it may be. And you need a commercial lens that can give you a view about the value proposition. So it's not just that it's a good idea. We have to consider the issue of affordability, because somebody is going to end up paying. And at the moment, our system is skewed, and one of the biggest challenges for middle management in the health system is getting that balance right. And so if we could start a wee bit earlier and understand the imperatives associated with a commercial understanding the finances, understanding resource management, and how you bring that to bear in your decision making so that you can get the best value, I think ultimately we will have a better and more equipped workforce. There are two more points that I'd like to make. One of them is about the complexity. There's a theorist called Dave Snowden that talks about the theory of complexity. And what he says is there are simple problems that we can solve immediately. They're generally transactional, and that's absolutely true. There are complicated problems that if we break them down into chunks, we can solve the chunk and we just need to put it together. And there are complex problems that we actually don't know a lot about. And what we have to do is we have to assault that problem with what we call safe-to-fail initiatives, where we bring our promising practice and our best knowledge to bear and we trial and test new ways of working. I think this methodology has merit and consideration within the health system because of the complexity that you're having to deal with. And it's an area that I think we really need to bring into play so that we've got a stronger culture about adaptive learning, where we have safe-to-fail experiments, and we wouldn't want that in the public domain because they would misunderstand what we're saying, but we really test out new ways and new approaches to solving some of the complexity that we're talking about. Because for patients, for people that use the health system, they don't just sit in the health system, they sit in the community, they have family lives, they have work issues, they have income issues. There's an array of factors that influence their health and well-being. And when we think about responding to them successfully, particularly for people with chronic disease, which will typify the cohorts in the future, we have to think more holistically. And we haven't got the solutions today, so we have to learn, and we have to learn on the job. So more flexibility around that, I think, is really critical. And then the final point is about being more strategic. We have to acknowledge that change is the norm. It actually was the norm when I was a student some years ago. And we don't have a system to bring together external information to inform our thinking. We tend to look to that which we know, which tends to be within discipline, within the health system. There's actually a big world out there, and that big world has lots of really good learnings, and learnings in terms of successes and mistakes that have application in the health system. And we have seen a trend over the last sort of 5 to 10 years where there is an increasing appetite. But we need to bring our graduates forward with a wider view of the world so they understand how systems work, understand the political process, understand the relationship between government, understand how communities work, understand how the health system works, not from the perspective of their intervention, but the interplay. We don't have a lot of that capacity at the moment because people have been so focused on their technical capability, and we need to widen it out. And I think if we can bring those broader-based skills into play for our graduates, we will better prepare them for the work that they will have to undertake in the future. On that note, I'll conclude.
Thanks very much, Liz, and I think it ties in nicely with what Heather had to say when she described the subacute area of Wagga Hospital and how teams are evolving and having to engage in new ways of thinking and conceptualising problems and indeed understanding the system. It's a good opportunity to turn to our third question, if we could please, which deals with how can we more effectively train allied health professionals to understand their role as part of an interdisciplinary and multidisciplinary team. So there are your choices, and see how you vote. All of the above. Well, nothing like an eclectic solution to a complex problem, is there? Heather, this is a magic moment for you. What we do in the university and in the hospitals and the community in providing training opportunities for future health professionals will count for naught unless it's sustained in the health system. And Heather Gray is the Chief Executive Officer of Health and Education and Training Institute within the Ministry of Health, and she commenced in that role in March 2012. 212. That dates you, Heather. I'll just emphasise that's AD, not BC. And she's had a wealth of leadership experience with a distinguished career spanning more than 17 years working in senior executive roles. Actually, Heather and I go back a long way to when we were starting the rural school at Broken Hill, and she was nursing there, I think. Were you director of nursing?
Chief Executive.
Chief Executive at Broken Hill Hospital, yes. And then we had a second incarnation when she came to assist us with the Western Sydney Local Health Network, I think as it was called then. But then bigger things caught her attention. She was going to resign from everything and went off and did a tour, and the board is so senseless that she had to rise to a new challenge, and that is being Chief Executive of HETI. And so Heather, I've always had a tremendous admiration for your commitment to high quality care, and the contribution that you've made to it most recently has been incredibly worthwhile and positive, and so we look forward to what you have to say. Thank you.
Thanks, Steve.
Sometimes I think driving a Winnebago around Australia with my 2 border collies was easy in comparison to undertaking the role of education and training in the health system. And the Minister, Kathryn and Liz have all stolen my phrases, my words, everything about reform. So I'm just going to focus on a couple of issues that I think really need a shake-up. Why is it that the universities still train nurses and midwives, medical students and allied health professionals separately, apart, different language, different curriculum, different ways of doing things. When is it that we're going to have a generalist health education course for 4 years that gives us a generalist health worker that can do a range of tasks and be in the hospital, in the community, and then we get to specialise later? Now, I have to leave now because I'll probably be run out of town from all the people who are professionals. This is not, from my perspective, demoting or downgrading what we're doing. It's coming back to what the Minister's saying, what Liz is saying, and Kathryn's saying. We need the team. We need the teams across for the patient, and the patient needs to sit in the middle of what we do and how we do it. And we need to train in that way. And we need to train in that way not only in the university sector, but we need to train in that way across in the public health system. And I've got two of my favourite people here today. Stephen Leder taught me a lot as Chief Executive of how to relate to doctors. And actually, I got to understand from him about how to relate to doctors. And that, Stephen, was a lifelong achievement to understand how that thinking worked. I'm not sure I've got it always right, but it's that relationship between the doctors, the managers, the clinical people that need to come together. And my privilege of being in the heady role, and I'll tell you one story, is working with Danny O'Connor and Stephen and working through what we're calling the clinical executive and leadership program, where we're bringing over 100 people together, 50 clinicians and 50 managers in Westmead, and re-looking at the relationship, the culture, how we're doing business, how teams work. Danny is not the heroic leader anymore. He's become the adaptive leader in working with his group of people, with you. So we've really got to change the way we're delivering training, how we're doing training, and how we're working through training in the public health system. And Hetty's starting that journey, slowly but surely. We've started working on what we're calling some foundation training units, which are multidisciplinary and go across for the new graduates, online and over a process of time, working with their senior people in the hospitals. So we're starting small steps. The clinical leadership program we're starting is working inside the hospital. We're changing the culture inside. We're not taking people out, we're bringing them in and working that through and showing ways to work more effectively together, bringing the clinicians in with the managers and working out ways to improve that hospital for patient, improve patient outcomes. I think the other part about training and education that's really critical is how are we doing it with the graduates? And I was absolutely delighted to hear what Kathryn had to say about the change of what's occurring. But think about clinical placements. We've been doing clinical placements in the same way, in the same manner for 1 trillion years. I think it might have started in the 12th century, but somebody who's got a history background can probably pick me up on that. But we send them out, we put them next to a clinician and say, learn by watching, observing, whatever. We have no real good evidence that that works. We don't actually measure it. We don't actually know whether Cliff Hughes is an outstanding supervisor or whether Teresa Anderson is absolutely brilliant and fantastic. We put them out there, we give them a time, and then we take them back in and somebody ticks them off and marks it. What did they learn? Are they competent? Do we know? We don't measure. We don't understand even the system we have of how we do that. And we don't cost it. And we keep increasing the numbers. And a lot of our people who come into the public system end up in the private system, which is fair enough. But where's the private system supporting the clinical placement? And where's the business argument, Liz, about how does clinical placement work? We know that simulation education has got some proven track record, has got some evidence. Why aren't we using teams of graduates putting their clinical placement through simulation and actually getting some decent evidence and measures about whether that works? Cut down the time spent in observing and get it into simulation. So I think simulation education really can take off in lots of ways across the interdisciplinary. The Minister, when I think about the first week, and Teresa Anderson is responsible for this as well, I turned up at an opening and I have a semi-trailer, which is a SimLab on wheels, and it's truly a semi-trailer. That has now trained nearly 2,000 people, clinicians, in team scenarios. Quite fantastic feedback that we're getting in relation to that occurring. So I think we've really got to rethink what we're doing with clinical placements, and why are clinical placements basically all in hospitals? Why aren't they out in the community? We've started work on it. We've obviously got people in GPs, centres, and we've got some community, but I think it probably should be 70% out in the community arenas, not in the teaching hospitals. So we've really got to think about, I think, the clinical placement issue and how we supervise, how we measure it, how it's done, why is it done, and why do we have, Kathryn, 4 years? Why is everything in a university 4 years, 6 years in terms of training? If somebody's competent in 3, why can't they be qualified? If they're competent in 2, why can't they be qualified? And out they go. Why are we locked into a lockstep approach that I think might go back to the 1st century in terms of the training? We're not measuring the training, we're not looking at competency, we're locked into terms, we're locked into the way of doing it. So I think there's lots of challenges when we come to reform, and I think it's really interesting, Minister, hearing about Wagga, because in the early days I was down in that patch and remember the planning conversation, so it's an absolute delight to hear how it's working. But when you've got teams of people working together, putting the patient in the centre, you don't need the disciplines as formally as we've got them at the moment. And we really do need that approach, I think, to break the apprenticeship model and break the training model and do things that actually make it work for the patient. Because does the patient actually know that they've got a doctor in front of them, a nurse in front of them, an allied health professional? They want somebody who cares. They want somebody who can help them. Sure, we need the specialists, and we need that absolutely fantastic technical, but we need those things that Liz is talking about, teamwork and interprofessional skills. I'll stop there, Stephen. Thank you.
Some real challenges in what Heather's had to say, thank you. And we've got time for 4 questions, and it's a case of first in, best dressed.
Lindsay Kane from Royal Far West. It's a statement, an invitation to comment, that there is a hybrid group doing public purpose work out there that I think are not seen enough as being providers and supporters and resources. And I'm talking about a coalition of non-profit organisations. There are many non-profit organisations in this room. There are many non-profit organisations working in health that can take placements, that can do many things, that are actually community focused already. You talked about you have a good right hand and a left hand, Kathy. No one looks at the whole. I think I'd challenge that, and I'd say a lot of community organisations have a community focus. They're there, they're public purpose organisations, but they're not public sector, they're not private. And I would challenge you to say there's a coalition of resources there that are waiting, hoping to be included and able to provide resource to the system. And I invite you to comment.
I think you're absolutely right. One of the issues that KPMG has been considering recently is taking a health economy focus, because I think we have been too imbalanced, focusing only on the public system, because ultimately it is about the network and the interplay of the actors. And it is about the public system, it's about the private system, and it's about the not-for-profit system. And I'd also go further to say it's not just about health, it's about the aged care system, and it's about the human services system. And these artificial boundaries we have created has actually impeded and optimised fragmentation. And what we've got to do is go back to the point about seamless care and integrated care and work in community, in place, in an integrated way around the individual, their families and their settings, so that we can get the right solutions in place.
It's interesting, I was speaking with a former colleague from New York on the weekend about healthcare in the US, and he was making the point that there is no health system, but he said we've got hundreds, thousands, tens of thousands of non-government organisation groups who put the case, who do the work, who fill a lot of the gaps that are filled by government agencies and others. I think there's a lot that we can learn from the US for sure, and the role of non-government organisations and not-for-profits is certainly one that I personally anticipate strengthening in the future. Michael.
Could I just say something on that?
Please.
Lindsay I know very well. She's a member of my Rural Health Advisory team, and I've known for a very long time, just as I have Liz. And one of the things that I understand very well from my previous life working in youth affairs is the huge value of working with those community-based NGOs, that and that is very much what I include when I talk about integrated care. So it is, and the skills you mentioned, Liz, the requirement of people graduating now of understanding that is not a second-class place to work. That is where I think the real reform is going to come from. Yes. Stephen, your point about saying health system, the reason why they, in my opinion, and the Director General Mary Fowler is fond of saying this, the reason why so much is focused on hospitals, and if the media has got any problems with health, they regard it as a hospital problem, is because that is the system. We need to make the much broader range of health service provision part of the system. Yeah. That's really what I'm talking about in community integration.
So I'd like to ask a question, not as Vice-Chancellor of the University of Sydney, but as Chair of the Universities Australia Health Profession Education Steering Group. That brings together all of the different health disciplines and universities across the sector to talk to governments and the health system more generally about training and the clinical placements problem in particular. Universities are in an interesting position at the moment. 50 years ago you taught people a bit of Greek and Latin, and you taught it to a limited number of people with large amounts of social capital, and you sent them out to employers who accepted that what they could do was a little bit of Greek and Latin, and accepted a heavy burden for in-workplace training. At the same time as the technical skills that our students need are increasing, not unreasonably, the community is expecting that also we should train people in some of these other skills that you're talking about. And I simply could not agree more. But one of the things that slightly concerned me in the presentation was that there was a suggestion that a person was a, as it were, completed sausage at the end of the education process to be consumed by the health system or by the private employer. And I think it would be great if Liz could describe what she thinks the duty of private employers is in relation to education, and if both the Minister and Heather could talk about what they think the duty of the health system is in relation to education.
And I just remind you, we finish it now.
I'd be very happy to talk about, in particular, doctors, because as you know, I convened a summit on internship, medical internship training a couple of years ago. It's now in the Health Ministers' Council, and it has been referred to the officers group to do some further work and consideration, and I know they'll be in touch with universities about that. But it was a very interesting summit, and out of it came some quite radical ideas about, maybe registering doctors at the end of their academic training and then having their further education part of what they do working in different settings, particularly community health. We are in New South Wales providing 960 odd this year internships, $105 million. It's a very big expense, and we're training a lot of these doctors to go and work in GP land and in private hospitals. So it's a very big investment from the part of the health system, the public health system, which we're willing to invest in, but I agree with whoever said it's a guild system, where we're doing exactly what we did centuries ago. So I think it's important to have that experiential learning, but we need to actually evaluate it and see what the outcomes are and whether we can do it differently. I've just talked about medical there, but It's the same thing with nursing, although I think probably more of their work, the experiential work is done at the workforce. And I've been thrilled recently because there was a shortage of midwives, for example, and when I first became the minister, and it seemed almost an insurmountable problem because we had made a commitment through the Nurses Association to increase the number of midwives. What's happening is the districts are now training their own on the job. So there are things that have emerged because of these demand for workforce.
And just briefly, from a private sector perspective, I don't want you to train them up in all of those domains that I've just flagged, but I'd like you to orientate them. I'd like them to come out knowing that those capabilities, skills and approaches are actually part and parcel of the work that they'll be doing in the system. So it's not just about the patient, it's not just about their technical capability. They have a wider suite of obligations so that it prepares them for a career path of whatever choosing that may be. I don't think at the moment there is enough opportunity, and what we've got to bring, I think, to the table is diversity of opportunity, because that's what those graduates are going to confront, and the more they can be earthed in it and experience it, the better choices they'll make, and it hopefully means they'll stay in their professional arena and sector.
So our time is almost over, and I'd like to ask Kathy to conclude and perhaps canvass with you what the next steps would be, because it would be a shame to lose the momentum of this breakfast gathering and dissipate it without any solid achievement. So, Kathy, the floor is yours, and then we'll
Don't give me too
we'll
much
finish.
floor. Can't get me down again. They all said they gave me 2 minutes each because it was really important for people to hear the vision of the faculty and what we're actually trying to do. And it sounds like there's furious agreement up here, so if it was up to us, we could just change things tomorrow. But all the issues that you've raised are really important, and they do tax us, and particularly the issue about clinical placements, because it's central to students' education, and they're very powerful role models. Whatever we like to think, they are powerful role models, and that's where they are socialised and acculturated. So it's really critical that we work closely together on the same agenda. So I guess the questions, everybody agrees that to enable health workforce for the future, we need to use all those different methods about multidisciplinary learning and all the different skills and working together. So how are we going to do that? So more than 70% of people agreed that we need to be working together across the disciplines and across the sectors. We need to find a way to do that. It's all very well to agree, but the barriers are enormous, and they're tiny little things like timetabling, but we've got to overcome them and do that together. The new way of working, we need to work to discuss that into the future, because we don't really know what it is. And as Steve said, the main thing we know is that we don't really know, that we know for now, we know for the next couple of decades, we don't know after that. So that's the landscape we're working with. We need flexibility and understanding systems. The business argument that Liz was, the proposition about understanding the business is also really key piece in the puzzle, and everyone doesn't know yet, but the university has been leading just such a project to look at the business model, particularly for costing clinical placements. We get a lot of feedback about the value, not just the cost and how draining it is to have students, but the value of the energy and the latest research being there and the service that they provide. And the young staff love it. They love to have students, they love to do research, and by stopping that, you're losing your best staff. You can't retain them if you're not engaging them in those activities. So, and I would just like to add, when I said that we need friends, or I need friends, I mean it, and thanks for the advice about join Facebook. I mean real friends, and I am on, I'm on Twitter, and I do have a blog, so it's all cool. But if we are signed up to this vision, we need to be working together to achieve it. It's not a fully formed vision. There are some parts of it that we understand, but we need to shape it together. And why I have some young staff here is because they truly are the visionary ones. It's not really us old bags, I keep saying, but we're medium. I understand we're medium now until you're really old, and that's self-report. So where to from now, Stephen and I will write an op-ed, right?
That's right.
Yeah. And we are thinking that it should not be a talk fest. We're hoping that we will be able to work together to shift forward. So what is the best way to do that? You've got the clickers, but would you like to meet again? Will we have more of these? When we did the first one last year, we couldn't get people out because they were so excited. And the collaborations that were established were enduring. So we've done it again this year, but will we have another forum, something like this as the next step to take the agenda forward? Yeah.
So, thank you very much again to everyone for coming, and thank you to our panellists who've stimulated our thinking and contributed in a lively way, Jillian Skinner, Liz Forsyth and Heather Gray, and of course to Kathryn Refshauge and her team in the Faculty of Health Sciences. Thank you for investing the energy and time in making this happen. It's been very gratefully received, and I'd ask you all to join with me in thanking Kathryn and our panel for a very informative morning. Good.